Thank you very much, Doctor, for your nice introduction. Yeah, yeah, pretty much everything you, I think um, I would say like you mentioned me a lot. I don't know how much I deserve, but definitely whatever among the homeopathic community, whatever questions you have related to cardiology, I'm happy to help you within the limit of my knowledge. I'm not going to tell you that I am the final word or last word in homeopathic cardiology, but I have been working in this field for around 20 years now. Um, but I'm a little bit away from many of the conference platforms. Sometimes I don't get time, and another reason is many practitioners are not very much interested in practicing cardiology due to some reason. Maybe it is risky, or maybe they don't like it. I don't know, but very few people are interested in this area. But we should think that there's a huge opportunity in clinical practice regarding cardiology. I would say that we have to more focus on metabolic medicine than cardiology, because down the road, cardiology, diabetology, obesity medicine, all those three will merge into one single disease. That's a metabolic syndrome. And down the road, there may not be any standalone cardiology. They'll be like, because all those three diseases are the expression of one single syndrome. That's the metabolic syndrome. So in homeopathy, we have more holistic approach. So for homeopaths, it's more easy to amalgamate cardiology, metabolic medicine, obesity medicine, all those things you can amalgamate together into one single platform. And the benefit will be tremendous if you consider cardiology as a part of the metabolic medicine. But still, there are cases like you may get hypertension cases, dyslipidemia cases, you may get coronary artery disease cases. Preventive cardiology is one of the major area where we can play around. So yeah, hopefully more doctors will be interested. I won't say that junior doctors. I don't have any. I don't have a differentiation between juniors and seniors. And many times this question is asked to me: what's your advice that you are able to give to the juniors? Um, I don't have any advice to give to them, because there is nothing like junior exist in my terminology. Everybody has different level of knowledge and skills, but I would say those who are embarking on cardiology initially, probably they can get something from me. I don't know. It's up to their perception, but it's nothing like junior or everybody has their own knowledge capacity and their own perspectives in looking into um, clinical practice. Anyway, today's topic is, I would say, a little bit of boring, because we're going to talk about the new concepts in cardiology cases and a homeopathic perspective. The issue is I'll be talking mostly about a little bit off the track from like the conventional homeopathic format, like the case taking, the storytelling, and then coming to repetization, and then coming to a strange, rare, peculiar symptom and prescribing based on that. That's not the way I am dealing in cardiology. That's why it may be a little bit boring. You may have difference in opinions, but um, that's the way I'm practicing cardiology. It's basically more based on some protocols, because the pathology is really high when a patient steps into our outpatient department. So we have different protocols. I hope everybody is able to see my slides. If there's any technical glitches, just let me know, and those who are behind the control of this conference may be able to fix it. But from my side, I think I already shared the screen, and I guess everybody is able to see this. Is there any issue with?
No,
Yes,
no,
sir.
no.
Yes, sir. We can actually see this.
Okay. So what's the protocol-based treatment and what's the significance of it? The protocol-based treatment is the foundation or the cornerstone of evidence-based homeopathy. Because for me, I would say the future is evidence-based. So we have to a little bit change our things into an evidence-based platform. So the protocol-based treatment becomes a cornerstone of turning into or stepping into an evidence-based homeopathy. So what's the advantage of protocols? Just let me, there are messages. I don't know whether it is to me. All right. So the evidence-based it's more foolproof. The individual capacity of the homeopaths or the practitioners may differ. Some people may really excel in analyzing the case, going to their individualizing symptoms and prescribing one constitutional remedy. But another practitioner may not be able to go in that direction. So there are differences in practicing ways. But if you have a protocol, everybody can prescribe. Everybody will make successful prescriptions in dealing a case. So that's more foolproof, that it doesn't matter how much intellectual capacity you have, but still we are able to make successful prescriptions. So that's an advantage of protocols, and if it is thoroughly verified. And it's a scalable platform. That means it can validate and include clinical experiences of homeopaths. That if somebody is telling me that I prescribe this particular medicine for hypertension, if I have a protocol for hypertension, I can look into that. I can do really trials on different cases. I can put people to review it. I can sharpen it. And finally, I can incorporate that evidence into the protocol. So it's more scalable. It's not like a closed room. We are able to scale it. We are able to expand it. So that's one importance of protocols. And it enables retrospective studies and revision of protocols. That if there's another person come in with another protocol, then I can go or our team can go and look into that, and we can go to and we can validate it. We can do retrospective studies from their case files. We could eliminate the technical issues there. We can filter it off. We can funnel it off and take the cream of it, the crux of the protocol, and we can incorporate into a new protocol. So that means the protocols are revised very often. It's not closed room. We are revising it every year. If we have a protocol for hypertension, basically we are using some protocols of Canadian cardiovascular, homeopathic. So there's a cardiovascular society for homeopathic cardiovascular societies, and we were basically working on the protocols on that platform. And the very important thing is teamwork is possible. That's one really missing in homeopathy. Every individual has an individualized way for prescribing it. Some people will trust on predictive homeopathy. Somebody will be like, I don't know, there are different schools. I can't even remember all those schools. But everybody is successful in their own way. I don't blame anybody, and they let them go ahead with that, their own systems. But eventually what happens is teamwork becomes impossible. So if you have a protocol and if you have a revision protocol, it's more easy to work on a team. So that's another importance of protocols. Okay, so now I will be telling you a couple of things about how incorporating different investigating modalities in prescriptions. Incorporating ECG findings. I would say you may see some spelling mistakes in my slides. I could see a mistake here. The thing is, unfortunately, these slides are not prepared by me. It's my office. I gave all the content to the copywriter, and they are making in my college. So they made the designing and stuff. There could be some errors, but on while going through it, I will correct it. So incorporating ECG findings in prescriptions. Remember, ECG is the word we use in India. There may be other participants from other part of the world. So if there's anybody from United States or Canada or in some other parts of the world, it could be EKGs. So and remember, EKG and ECG are the same. So example, spongia becomes a leading remedy in sick sinus syndrome. So that's a very clear, straightforward prescription when we are seeing in a sick sinus syndrome in an EKG. So that's how we are able to incorporate EKG findings. And there is no other way to diagnose a sick sinus syndrome other than an ECG or EKG. You're going to see cases with no other symptoms. If the sinus rhythm is like probably maybe around, the patient's pulse rate will be around 65 to 55 to 60, the patients may not show any symptoms, but when you palpate the pulse, you may get the pulse rate very low, like 60 per minute or 50 per minute. But the issue is you're not going to get a diagnosis of sick sinus syndrome until you get an EKG, because the low pulse could be due to any other reasons. Maybe the patient may have hypothyroidism. We never know. So if the case is a hypothyroidism, spongia, yes, spongia could be a remedy for hypothyroidism, but not very specific. So there are other medicines for hypothyroidism, like thyroidinum is another medicine, bromium is another medicine. There are many other, Jugulant is another medicine. So there could be like many other medicines for hypothyroidism. So, but if you see a sick sinus syndrome and it is verified in ECG, we can straight ahead go into spongia, because we have been verifying the effect of spongia potencies for this sick sinus syndrome for a very long time. So that's one straightforward prescription with ECG findings. And if a patient has sinus tachycardia on the other side, so sinus bradycardia and finally going to sick sinus syndrome is one case. If you go to exactly the opposite, the patient have sinus tachycardia or tachyrhythms. And sometimes it becomes very challenging in our outpatient department. The patient presents with high pulse rate with no reason, and you order an EKG, and it's 100% clear that it is a sinus tachycardia. And that's why I'm telling you, sometimes my prescriptions, you may think a little bit off the track. So thyroidinum and nausea, sometimes we have to alternate both remedies, and then by alternating both remedies may not be agreeable for some practitioners. I'm trying to be intellectually honest. That's why I'm telling you the actual things we are doing. So we have to sometimes alternate these two medicines pretty a long time and keep on watching this person for reduction in heart rate. So these are two examples that there are many things, but we have limited time to present it. That's why I'm thinking that's a way to prescribe based on EKGs. Echocardiogram, cardiology findings. And we can correlate between remedy selection. I think there are a lot of spelling mistakes, unfortunately. EKG, echocardiogram in many countries, like in India, homeopaths can easily send for an echocardiogram. If you and in many other times, the patient may bring an echocardiogram report to your office. So ejection fraction is one of the major criterion for assessing the pumping of this heart. So Crataegus and Iberis becomes two major remedies you can prescribe based on ejection fraction. And I would strongly suggest Crataegus on a little bit more advantage Crataegus has on top of Iberis. For example, many practitioners prescribe Crataegus for no reason. It has been abused by many practitioners. They may prescribe Crataegus for conducting defects of the heart. Just looking into sometimes the patient may bring an EKG with atrial fibrillation or EKG with like a bigeminy or whatever conditions they are prescribing. And just because it's a heart case, homeopaths prescribe Crataegus. But if we really go into deeper aspects, Crataegus is basically acting on the myocardium. And down the road, it can improve the pumping, the pumping of the heart more, mostly like ejection fraction. For example, I can tell you a patient had a heart attack, and he has been he has been resuscitated in the hospital, and they are on medication, and they are like they like already like 6 months passed, and they are back into work, but they have a breathlessness on exertion, but the ejection fraction is low because they lost a significant amount of myocardium because of the heart attack. Very typical case of prescribing Crataegus, because the ejection fraction went down because of low pumping. So another case is the patient has cardiomyopathies, again myocardial issues. So it's mostly affecting on the myocardium, and many homeopaths are prescribing Crataegus for hypertension. I'm not against it, because the boost to strengthen the myocardium is okay. In hypertension, you may get results. You may think that hypertension has been controlled with the prescription of Crataegus, but may not be due to the prescription of Crataegus. It could be due to some other reason. So that's how the protocols are developed. If there is a low ejection fraction, it becomes an absolute indication for prescribing Crataegus. The conditions are post-myocardial infarction, cardiomyopathies. Two major indications are there already. And benign septal defects like ASDs, and the most common septal defect is VSD, but spontaneous closure of those septal defects is possible down the road. But in majority of the cases, we don't have anything to do there. They will bring the patients or the child to your clinic, and they will be really upset because they have a hole in the heart, and we know that will close eventually. I would suggest you can prescribe constitutional medicines to improve the patient's condition, because that can probably accelerate the closure of this hole. But there is one shortcut prescription which covers the miasmatic background and the defective cardiac structure. I would say Echocardiogram is one of the majority of cases that will be indicated. But if you have some other choices, that's definitely you go ahead with your choices. But I would suggest it. There is no backup studies to say that Echocardiogram is one of the best remedies, but I have been using for many years. I mean, my personal opinion is not an evidence. I'm just telling you, expert opinion is not an evidence. But if you have, so I'm just telling you that's not an evidence, but I have been seeing patients and prescribing it routinely. But some patients may, without any medicines, they get the closure automatically. So that's why no claims on it. But I used to prescribe cephalainum as an intercurrent because cephalitic miasm is mostly related to the structural heart diseases if you go into the miasmatic aspect. So if you're comfortable prescribing a miasmatic remedy, you can definitely consider cephalainum. Then what's the challenge in managing a septal defect? The only challenge is to prevent infectious and infective endocarditis, nothing outside of that. That's the reason this person has to declare that the patient has ASD or VSD before they visit a dentist, because dental procedures are notorious for infective endocarditis. So we need like infection coverage for the myocardium. So tuberculinum is routinely prescribed, and I used to prescribe tuberculinum in a lymphadency on daily basis until the hole is closed. For nothing but for prevention of infective endocarditis. Because if you go to the miasmatic aspect of it, it is a combination of syphilitic and psoriatic miasm, and tuberculized miasm is a product of it. It's a product of these two miasms. So that's the concept behind it, and that's not an evidence. Because it's very hard to tell why this patient has improvement. It's by itself or because of our prescription. But that protocol has been developed and it has been on testing for years and years and years, and still we are not able to say that it is a conclusive evidence, but we are using it successfully. I'm using it successfully. So that's one protocol that we can use based on echocardiography findings, because only echocardiography finding could tell you that there's a septal defect. There are other ways, like by auscultation. If you are getting a fixed splitting of S2, second heart sounds with a murmur, there's a high chance for that baby has an ASD. And if this child has a continuous murmur during systole, there's a high chance for ventricular septal defect. And in EKG findings or ECG findings, sometimes there could be like conduction issues suggesting an ASD. Those are all like roads going into the echocardiogram. And for a final diagnosis, you need an echocardiogram, and you have to have monitoring, continuous monitoring of this patient for prognosis. Couple of other things about echocardiogram. Left ventricular hypertrophy. I would strongly suggest to have EKGs and echocardiogram if needed, if you are keeping a hypertensive patient for longer in time. Hypertension, I would say every homeopath will be getting high blood pressure patients, because majority of the patients already taking hypertensive medicines. They are really fed up with the medicines they are taking, because they have to take all those beta blockers. They want to take ARBs, like angiotensin receptor blockers. They have to like channel blockers, like calcium channel blockers, and basically they're all blocking different functions of the body. So they are basically, most of the patients are worried about taking these medications for pretty long time. So they would like to switch into homeopathic treatment. So you get patients, but if you are getting a hypertensive patient, if you're keeping that patient for 10 years or 5 years, you have to have an assessment about the left ventricle. Probably you are doing a bad job. So down the road, there should not be any left ventricular hypertrophy. So routine EKGs will tell you some features about left ventricular hypertrophy, like a tall R wave in AVL, or you can get the prominent, the left ventricular hypertrophy, like patent deeper S waves in V1, V2, to taller R waves in V5, V6, those kind of findings you may get. But if you are not comfortable with reading an EKG, I would say just send the patient for an echocardiogram, and it's final. So because they can tell you whether there is a what's the left ventricular functions, left ventricular systolic functions, and you will get a real concrete report about the left ventricular function. So if the left ventricular functions are going down, that's the point when you can prescribe Crataegus, because the pumping will be affected gradually. If the ventricles going hypertrophied, that means pumping will be affected. So that's the way you can prolong the complications. So if you're keeping a patient for a pretty longer time, then investigations are mandatory. And then pulmonary protection with aspergillus. Sometimes this patient may with hypertension, you did bad job, and finally right side of the heart affected with pulmonary symptoms like breathlessness. Exertional dyspnea is one of the major symptoms of high blood pressure, but unfortunately, majority of the patients think that dizziness is a symptom of hypertension. When I was practicing in India, I noticed it. Many of the patients pop up in the clinic and they will tell me, "Oh, I have a dizziness in the morning, so I want to get my blood pressure checked." This is a typical presentation they make in the clinic. So, oh, today morning when I woke up, heaviness of the head. Oh, can I check my blood pressure? So, but they do not realize that breathlessness on exertion is one of the first symptom that. But if a patient, but we have to grade it. If the patient is telling you, I have a breathlessness on exertion, the pulmonary protection, that means if you are treating a patient with hypertension and the patient end up with left ventricular hypertrophy, still you are continuing the same thing. So who is there with a gun showing on the video? Justin Fokker or something. I don't know what's happening. I don't know, but it's okay. But for the admins, is that very common in these presentations? So Okay. Okay, so shall we proceed? Is anybody from the... Okay. Anyway, I'll continue. It's very interesting. Okay, I'm gonna share it again, the slideshow. All right, so let me know if there is any technical issues. What is that you attack from?
You can proceed, Dr. Sajeev.
Okay. Yeah, so pulmonary protection, if you're still continuing with the same way and this left side heart goes into wrong direction and then it goes to the right side failure, then it becomes more a major issue. So then we have to have a pulmonary protection. So that's why we can have a, so that I could see random things on my, so it's like, it's something really happening seriously. So how could they access my computer? And
I think the host can remove the scratches on the screen. Somebody may be scratching on the screen.
okay.
The host, please remove that.
Sir,
So what's the interest of these people in this in hacking the homeopathic presentation? I don't know.
man.
You can remove that XMAT Q from there, I think. Who is the XMAT Q?
Yes, sir. I'm removing. Yes, sir. I have removed it.
Host, you understood who shared the screen other than Dr. Sajeev before? Please remove that person also.
Yes, sir. I have removed it.
Yeah.
Okay.
Dr. Sajeev, you proceed.
Okay, thank you.
It's the first time happening here.
Okay, yeah. Anyway, that's a good experience for everybody that in fact in future we have to be more careful. Okay, so assess the prognosis of there I think more. Okay, yeah, anyways. Assess the prognosis of asthma treatment. So in an asthma patient, if you are treating an asthma patient, it's not cardiology at all. You're just treating a bronchial asthma patient. So for example, you are keeping that patient for 10 years and do not realizing that there's something going wrong in the heart because your focus is on asthma management. So if you are doing a bad job in asthma, what happens is eventually the right heart will go to failure. So that's why I put the aspidosperma there. So for pulmonary protection, sometimes we have to protect, that's the digitalis for lungs. Sometimes we have to prescribe aspidosperma for pulmonary protection when you are treating asthma patients. The best way is keep on checking the patient's echocardiogram and make sure that there is no right heart failure or the check for the right heart issues. And it goes blue screen over and over again. I will have to Every time I have to restart. Anyways, I will go ahead, no problem. And echocardiogram for murmurs in children, you have to definitely check the echocardiogram and make sure that that's an innocent murmur. For example, tuberculinum and syphilinum, yes, just like to prevent echocardiogram if there is any structural deformities of the heart to prevent infective endocarditis. And sometimes there'll be flow murmurs in children because the child's aorta may be like too much bend. So when the heart is pumping, there'll be a gushing of blood through the aorta, and you're going to get flow murmurs. They are innocent murmurs, but you could definitely go into innocent murmur. If it is an innocent murmurs, definitely if you go to the miasmatic background, it's definitely an antisoric because there is no structural heart disease. If you are prescribing based on miasms, and I'm just telling you, you can consider it as a soric miasm because there is no structural damage, and the child will get rid of that murmur as the child grows. It will go away. And TOF is a really dangerous condition, like tetralogy Fallot. So it is surgical, and if you want to give any palliative treatment to improve pumping protegus, to improve conductions, you have other choices like Veratum Virdi, and you have convaluria there, you have digitalis there. I will a little bit talk about that. Okay, so defective valves. Ginkgo biloba is an antiplatelet agent. So if the patient has a defective valve, there's just a high possibility of this patient ending up with stroke because of the clots, or sometimes there could be pulmonary infections. In all those conditions, you could definitely consider ginkgo biloba as an antiplatelet agent on top of the. So these are all prescriptions on top of your regular constitutional medicines, on your regular medicines. Okay. Angiograms. Angiograms definitely help you in a candidate selection. If you are getting a young person with obstructions, and somebody is again scratching on the screen. Yeah, angiogram, and so I'm not putting the. I will put the slideshow whenever needed. Otherwise, I will talk, and there may not be an issue. In candidate selection, so for example, a young person, like a 40 years old person, is there with even 30% occlusion of the coronary vessels, it is risky because that person may get heart attack at any time because that person has a very young plaque. They are very vulnerable to heart attack. But if you are getting a patient of 80 years old with even 90% occlusion, you could even safely treat that patient because that plaque is a non-vulnerable plaque. The plaque has been formed over a period of time, and it is strong like a concrete. It's not going to break off from that. That's why I always tell you the goal of treatment in a patient with coronary artery disease is not to remove the plaques. The goal of treatment is to prevent a heart attack. So you have to clearly talk that to the patient. Sometimes the patients will keep on annoying you. I have been into your patient for and do not give any assurance that we're going to peel off that plaque, because that's more dangerous than staying the stable plaque there. The patient may have quality of life issues. For example, a patient with 90% occlusion may have a stable angina. Whenever they climb steps, they do exertion, they have chest pains. Doesn't mean that they are vulnerable to heart attack. And other patients, with a young person with 40% occlusion or 35% occlusion with no symptoms at all, may end up with a heart attack. So that's why the goal of treatment is not removing the plaques. The goal of homeopathic treatment is to prevent second heart attack or the first heart attack. Sometimes accidentally a patient may get an angiogram with occlusions. For example, a patient is reporting that my brother had a heart attack at age of 40, and he's admitted in the hospital. Last week, he is in the hospital. Then you have to clearly tell them you have to get an angiogram because you have high risk. And probably that patient will bring with an angiogram report of 35% occlusion with no symptoms. He's perfectly healthy, but that's a vulnerable patient. There's a high chance of a heart attack. All the numbers has to be within the limit. So that's why angiograms will help you in selecting the candidate for treatment. So I would suggest, from my perspective, we are not able to take all the patients, even though I would say in cardiology, in other departments, it's up to you. We are not taking all the patients. We have a criteria for candidate selection. If it is a good candidate for me, I will take him. Otherwise, I have to tell him, sorry, I'm not going to be able to treat you. So sometimes these previous angiograms are helpful for candidate selection. And that sometimes will help you in therapeutic lifestyle changes. Curcuma longa as to prevent coronary inflammation, because curcuma has been very effective in the treatment of CADs, coronary artery disease. So angiogram reports will definitely help you in prescribing curcuma because it's a really wonderful remedy for preventive cardiology. Okay, yeah, so I will quickly put it again. So Holter monitoring, you could see paroxysmal atrial fibrillations. That definitely you may get in Holter monitoring, and you could you know that veratrum viridi is one of the best remedy for best medicines for AFibs. And convalescentia digitalis, these are the three leading medicines for AFib. And so Holter monitoring reports will help you in prescribing those medicines. Among those three, I would say veratrum viridi is one of the best. But remember, veratrum viridi is highly cardiotoxic. So you have to be very careful in prescribing it. Do not prescribing in a very lower potencies. And do not prescribe veratrum viridi mother tincture for kids with fever, because it is very cardiotoxic. I know that I have seen that many of the homeopaths are prescribing veratrum viridi mother tincture for kids with fever. Calculi RC is another medicine for palpitations, so you can definitely try those. Ginkgo biloba, I put it there because atrial fibrillation is one of the major causes for stroke. So undiagnosed or undetected atrial fibrillations may be a cause for CVA. So that's the reason at some point, sometimes we have to prescribe ginkgo biloba as an antiplatelet agent in these cases. If you check the stroke patients or CVA patients, 1/3 of the CVA patients have undiagnosed or undetected atrial fibrillations. So this paroxysmal atrial fibrillations may throw emboli into the system, and that can definitely make a CVA case. So at some points, if you think that this patient has atrial fibrillation and other risk factors are there for vascular protection, ginkgo biloba becomes one of the choices. Yeah, I will put this slide just for a while. Then if somebody cancel this, then yes. Screen share option is disabled. Right? All right, that's fine, no problem. I will just tell you the things.
Okay.
Hematology or serology, sometimes it overrides materia medica. That's what I think. For example, rheumatoid heart RHD. symptoms matches with calmia, but from many clinical um, descriptions by homeopaths, I came to another conclusion that Naja rewards better in those cases. But if you look at, this is not my opinion. I talked to many homeopaths, those who have successful results in rheumatic heart diseases. But if you look into the materia medica, the symptoms of calmia exactly matches with rheumatic heart diseases. So that's why I would say that sometimes hematological and serological information overrides materia medica, the conventional materia medica. And sometimes angina due to severe anemia.
Just a minute, doctor. Host, please allow Dr. Traciama Matai to enter. Hello. Dr. Traciama Matai. She is waiting. Please allow her to enter our Zoom meeting. Thank you. Proceed, Dr. Sajeev.
Okay, thank you. Angina due to severe anemia. I have a very personal experience in a case like years ago. A patient has been really confirmed as a patient of coronary artery disease because this patient has exertional chest pain. It's very typical. The patient has exertional chest pain. So, but that patient, when I checked the blood work, that patient was severely anemic. And that severe anemia was the reason for the angina. And this anemia was corrected with constitutional medicines, Ferromet, lecithin, those kind of medicines, and the patient that symptoms went away. So that's another area where we have to be very careful and we have to be trusting on some investigative modalities on top of the materia medica and symptom spectrum. And another thing is dyslipidemia. It's very hard to treatment, cholesterol. We need specific protocols sometimes to deal with dyslipidemia patients because the symptoms will be very variable, and there are many many variants and in a dyslipidemia patient. This is not one single cause for dyslipidemia. The therapeutic lifestyle changes, diet, medicines, everything has a role in controlling dyslipidemia. And on top of that, patient self-commitment. Basically, we do not give much emphasis on that area, that patient self-commitment. If the patient is coming to a cardiology condition into our homeopath's office, they have a commitment to adhere to the advices and the medicine that we are giving. So that we have to clearly tell them, you have a commitment. If we are prescribing a product like a therapeutic lifestyle changes, that's a prescription. You have to do exercise, you have to do follow this diet, and you have to follow this. That's a prescription. It's not, so you have to follow it. So okay. So I'm gonna go to the next one.
Sir, can you try to share one more thing?
Yeah. Clinical medicine fixes subjective symptoms and fallacies sometimes. We always very much interested in the subjective symptoms and feelings of the patient because the patient is telling a story and we believe it. It may not be correct sometimes. Their story may not be correct. So clinical medicine, knowledge in clinical medicine is very, will help us to fix the fabricated stories by the patient. And if you are trusting on the fabricated or cooked up stories of the patient, we may really go wrong in prescription. For example, hysterical palpitation. A patient is telling you that I have palpitation. There is no way to check whether it is correct or not. If there is a true palpitation, we have to think about veratrimidity, convallaria, digitalis, strophanthus. There are many medicines in that direction. But this may be a typical hysteria. If it's a hysteria, you're going to prescribe natriumur, agnesia, many other medicines. I'm not dealing with much of the hysteria patients, so probably you may be having more expertise in treating hysteria or other mental health issues. See, if I'm asking that patient, could you please tap your heart rhythm on the table? The patient is claiming that I have palpitation. So that means the patient is experiencing the heartbeat, dum, dum, dum. Okay, go ahead and tap that on the table. While the patient is tapping on the table, I am auscultating the patient. I'm getting the real rhythm of the heart. The patient is supposed to tap the same rhythm on the table. If he or she is not able to, that means this is hysterical. You don't have palpitation. Sorry, you don't have palpitation. So knowledge in clinical medicine sometimes will clear many of the subjective symptoms that the patient is presenting to us, especially in cardiology. Maybe in other departments, you can definitely work on those kind of things. So that drastically changes the medicine selection. Another thing is individualization versus stereotype clinical settings. I would be able to tell you a couple of the stereotype clinical settings, not in cardiology, in an acute care settings. For example, you are sitting in your outpatient department, a child is brought, like a 5-year-old child is brought into your clinic by that child's mom. And we're going to ask, oh, what happened to this child? Oh, this patient, my son has sneezing in the morning. Okay, what else? Yeah, oh, sneezing and a little bit of the a running nose, and yeah, and throat irritation. It's again hacked, like throat irritations and kind of. Is the child has fever? No. Yeah, sometimes there'll be a little bit of fever. In the morning, I checked. Yeah, I felt like a little bit of temperature. Then you checked it, and there is no temperature. Is there any cough? Yeah, occasionally cough. It's a typical stereotype presentation. You may see a good number of patients like this. Another child is brought into your clinic. What happened? Oh, this patient, oh, my son has cough. Any fever? No. Is any sputum? No, like dry cough. Even if you dig more and more into that case, in most of the case, you're not going to see anything from there. There are a lot of stereotype clinical settings, presentations in your day-to-day or in outpatient department. From my perspective, it's very hard to go to individualization in all those cases. And you will not reach anywhere. You will reach nowhere by going digging and digging into that case. And I have seen case case histories presented by homeopathic doctors in many forums that they went through that case over and over again. After like 5 visits, they found a very peculiar symptom and prescribed it and fixed that issue. I cannot trust it.
Why?
Because for five visits, like a month, this mother has to bring that child with the same symptom for 5 months over and over again. That's not good. So if you have some really stereotype prescriptions for a stereotype presentations, done. That's what I believe, because I have seen many homeopaths prescribing like that, and they have a really good success. So individualization may not work in all cases. That's my perspective. So stereotype clinical settings and clinical presentations are always there. So we have to really focus and really work on that, and we have to have a like fast track prescriptions on those areas. So it's really important in cardiology, because the majority of the cardiology cases are stereotype presentations. I'm gonna show you a couple of stereotype presentations in cardiology. A 56 years old gentleman undergone CABG, that's bypass surgery, 1 year back, no chest pain, leading normal active life. It's right away hacked. Yeah, somebody is behind us. Never mind, I will read it. A 56 years old gentleman undergone CABG 1 year back, no chest pain, leading normal active life. Yeah, that patient is hypertensive, 150 over 100, that's the blood pressure. And it is not controlled with medications. No dyslipidemia, consulting homeopaths for a keloid in the chest because he has undergone a CABG. A patient came to the office with showing you a keloid here because of the CABG he has done a couple of 1 year ago, and the keloid is mounting up. And it's a 56-year-old gentleman, and the CABG is done. That means all their coronary vessels are fully open. That's done. Patient has hypertension at 100 over 150 over 150 over 100. And the patient is on blood pressure medications. And we know that 150 over 100 is like a stage 1 hypertension. So, but the patient is talking about the keloid. Then second stereotype presentation. A 67 years old lady with unstable angina, with a history of heart attack 2 weeks ago. And that patient has been resuscitated in the hospital and discharged. It's now 2 weeks and presenting into your clinic with unstable angina because that woman has been your patient for many years. Because of chest pain, she ended up in the hospital and she had a thrombolized and discharged from the hospital. Now it's 2 weeks and then coming to your clinic with an unstable angina. What to do? Then the third case, a 45 years old man with unstable angina on proper medication and follow-up in a cardiology center. And that patient is willing to fully switch into homeopathic treatment. Because they heard that in homeopathy, there is a good treatment for coronary artery disease. She read an article in a magazine. Somebody wrote an article, so she thought she could switch 100% to homeopathy, and she's stepping into a clinic. And this patient is a 45 years old man with unstable angina, and he's on proper medication and follow-up in a cardiology unit for cholesterol and blood pressure. So 3 challenging cases, but this is a stereotype. You're going to see, if you start really seriously focus on cardiology practice, you're going to see hundreds of stereotype cases stepping into your OP. So that's why it's hard and challenging, and we have to have specific protocols to deal with those conditions. So I'm going to tell you, if it is a 45 years old man with unstable angina, and that patient has all the cholesterol and blood pressure numbers properly kept normal in a cardiology unit, and he developed unstable angina and stepping into my clinic, I'm not going to touch that patient. Because that unstable angina can at any time precipitate into heart attack. Sorry, you're not a good candidate for me, so I'm not taking it. But a 56 years old man with a stable angina, with 56 years old man with bypass surgery done with hypertension and keloid, I will take that patient. Because the only goal of treatment is preventing second heart attack. In the first case I described, I cannot prevent a heart attack. So I'm not going to take that. In the second case, I can prevent a heart attack if I am able to keep the numbers normal. And if I'm able to control the coronary inflammation, I'm able to prevent a second heart attack. So that's the goal of treatment.